All right, guys, so we're going to continue our discussion around dialysis access. We were talking about ways to surveil for impending access thrombosis, and we set that in a background statement that none of these interventions actually has clearly proven to be beneficial in terms of access survival. With that being said, there are also some interventions that have been shown to have very modest effects on access thrombosis rates. Actually, Miguel Vasquez was one of the study investigators for these dialysis access trials. And one of the interventions that was found to be potentially beneficial in keeping grafts patent in the so-called DAC study. It was a combination of aspirin and dipyridamole that seemed to reduce some of the rates of access thrombosis for grafts. There was a separate randomized controlled trial that showed benefits from fish oil therapy. Now, the benefits from fish oil were actually pretty significant in that study. That being said, it has not been reproduced and shown to be that beneficial in another randomized controlled trial. One can argue, however, that's quite a benign intervention and so can be considered. Now, when looking at AV fistula patency rates, clopidogrel had some very modest benefit in terms of fistula patency. So we have some interventions, but they are very modest in treatment effect. I would tell you that even though there were some positive p-values from these randomized controlled trials, this is not translated into standard practice in keeping grafts and fistulas patent. Moving on from access thrombosis, we will talk about aneurysms. And the most common aneurysm that you're going to encounter is a so-called pseudoaneurysm. Pseudoaneurysm refers to the fact that most aneurysms are not contained by the three walls of a normal artery. So usually you have an intima, a media, and adventitia. A true aneurysm would be a dilation of all three of those layers. Most pseudoaneurysms are in fact essentially holes in an access, right? You have an access, you have a hole in that access, and then you have the layer of skin above it. And you have basically a outpouching of this lumen, and it is contained simply by the skin and the connective tissue of that skin. So it is not a true aneurysm that most of the time you're dealing with. It's a pseudoaneurysm. Okay, this happens fairly commonly. We try to reduce the rates of aneurysm formation by doing by cannulating the access in different points. One way that that's described is the so-called rope ladder cannulation technique, where you're going up and down the access, where you're poking it over time. However, that's pretty inconsistent, and even with rotation of needle sites, you can still form these aneurysms. Now, there is another technique that contrasts with that rotating cannula or rope ladder technique, and that is the buttonhole cannulation technique. Now, buttonholes are describe a technique of access in which you have the fistula, you have the overlying skin, and you essentially create a track between that skin and the access that you traverse repeatedly. So you create a sort of somewhat epithelialized track between the access and the surface of the skin. Often there's a little scab that covers it. And each time you access the fistula, you unroof that scab and You clean the skin, obviously, and you use a blunt needle to traverse that channel into the access. Now, this is sometimes used for patients who are performing home hemodialysis. It is also used sometimes in center on certain patients, and that might reduce the formation of aneurysms, but does have some other downsides. Particularly, there may be an increased risk of access infection with the buttonhole technique. Okay, and it's hard to um, form a buttonhole. You have to access the fistula in that very precise spot and trajectory repeatedly to create the buttonhole. You need to have somebody who's very familiar with that buttonhole, accessing it again. And not all units will have these blunt needles. So you can see that when you have a patient that comes in periodically at CUH using a buttonhole, we often are saying, okay, we're going to access this fistula at a different spot, making sure to not um, uh, cause a problem with the buttonhole by using a sharp needle through that track and creating a different track because we're unfamiliar with that perfect technique for that individual patient. And then sometimes we don't have the blunt needles to use to access a buttonhole. Moving on, vascular steel is another access-related complication. It's unfortunately reasonably common. It occurs more commonly with larger fistulas than with the smaller radiocephalic fistula. So the larger the fistula, the more the flow and the more risk of vascular steel. Okay, so brachiocephalic fistulas and brachiobasilic fistulas are larger on average than your radiocephalic fistulas. And so the risk of steel is increased with these upper arm accesses. Typically, it's the fistulas, not the grafts. Grafts typically have that constrained size and don't typically dilate over time unless there's large pseudoaneurysms that are formed. So these are the fistulas that generally are predisposed more to steel, although you can have steel even with a graft in a patient who has a small vessel vascular disease in their fingers. Okay, now this would usually require ligation when you're having frank steel, where you're losing sensation and strength. It needs to be done as an emergency, really, because you can see sometimes irreversible loss of function in the hand when you develop severe steel symptoms. So this should be something that you are willing to elevate to vascular surgery quite readily if you're having any suspicion for steel. Now, you might say that, okay, if I had a steel event in my non-dominant hand, I'm going to ligate that fistula and just put in another fistula on the other side. Unfortunately, there's a reasonably high risk that you're going to get steel again on the other side because most commonly vascular disease is fairly diffuse and severe in equal proportion to both sides. That is to say, if you're having steel on one side, the same risk factors that have caused that peripheral vascular disease are at play on the other limb as well. And so many times, again, we're careful about simply moving to the other arm. High output heart failure is another potential side effect of fistula placement. Again, this is primarily with fistulas and not with grafts because of the increase in size over time from some fistulas, and can develop in patients when their flow is over 2 liters per minute. Sometimes you can see 3 and 4 liters per minute of flow through some of these fistulas. It can be quite massive and require downsizing. We don't usually have to ligate a fistula for high output heart failure unless somebody has simultaneously a very significant cardiomyopathy. I had managed a patient who had severe pulmonary hypertension with shock essentially, where ligation was performed. Usually this can simply be downsized in order to address the high output heart failure state. Graft infections, we're going to talk about in this next section. Okay. Any questions before we move on? All right. So these are access-related infections that we're going to talk about as a segue from access more generally over to access-related infections. The risk of these infections are quite high, or especially those with catheters in place. The median time to access infection is 80 days. So that suggests there's sort of a ticking time bomb that one must consider when you have a patient with a catheter in place. When you have grafts and fistulas, clearly that risk is much smaller. For fistulas, notice that access-related infections are still quite significant in risk for AV grafts, less than a year in terms of median time to event. What is the organism that you're typically dealing with? Usually these are skin commensals, these gram-positive cocci that include Staph aureus and Staph epidermidis in roughly 60% of cases. And then gram-negatives are also need to be considered, especially with the catheters. I would say with grafts, it's more likely to be these gram-positive cocci. But when you have catheters, gram-negatives are certainly organisms that you must consider, including Pseudomonas. So the empiric therapy for patients who present with concern for access-related infection must, in most cases, include coverage for Staph aureus as well as Pseudomonas. So empirically, we're using an anti-Pseudomonal, and depending on your site, and the prevalence of Staph methicillin-resistant Staph aureus, you might be using Bank plus an anti-Pseudomonal when you have a fairly high risk of methicillin-resistant Staph aureus in your particular practice environment. Okay. Occasionally, these are going to be polymicrobial. Notice that there's a pretty high chance of developing metastatic infections, including osteomyelitis and endocarditis, especially with eclampsia from Staph aureus. If you have Staph aureus related bacteremia from a dialysis catheter, you have to be asking your patients about unexplained back pain or new onset back pain, or paying attention to the cardiovascular exam, looking for endocarditis or osteomyelitis. I would say those are some of your most common metastatic infections that we see in dialysis patients. Okay, let's focus in on the catheter-related infections, and especially the catheter-related bacteremia, the eclampsies. We're going to talk about exit site infections and tunnel infections to follow. But again, when you have frank eclampsia, we are usually an anti-Pseudomonal typically, plus a Staph aureus coverage. And again, you decide between Ancef or vancomycin, depending on the prevalence of MRSA in your practice environment. Once you have an organism, you tailor the antibiotics. If you do get an organism, occasionally we do not have, a clear organism, and we simply treat with the Ancef or the vancomycin and anti-Pseudomonal for a total of roughly 3 weeks. I would say the shorter 2-week coverage would be for a Staph epidermidis. Of course, without metastatic infections, you might be willing to treat as short as 2 weeks. In general, we're committing to 3 weeks for most of these eclampsies. Okay, unless again it's Staph epidermidis, where 2 weeks might be reasonable. In some cases, I've seen ID even suggest if we have a catheter removed, maybe as short as 1 week for Staph epidermidis, when ID is pushing for a shorter course. Okay. You can consider reculturing after completion of therapy in order to document clearance of the infection, especially if you decide to do a guide wire catheter exchange. That might be um, especially that might be a consideration, especially in that context. So we'll talk about that catheter guide wire or that guide wire catheter exchange, I think, in this next section here. Again, antibiotics are initiated in a patient who's considered who might have CLABSI. So you draw the cultures, you give the empiric antibiotics. By the way, this can be done in the outpatient setting. Not every patient who has fever and a concern for CLABSI in the outpatient dialysis unit needs to be sent to the hospital. You can start antibiotics, okay? If they defervesce within that first 24 to 48 hours, you can manage a CLABSI as an outpatient. Okay, you basically, if they look good and all their symptoms are better by the time they come back to the dialysis clinic again, 2 days later, then you can, once you get an idea of which organism you're dealing with, you can make a determination that you want to do a guide wire catheter exchange. And that can be done as an outpatient, okay? And then you complete the duration of therapy of around 3 weeks. And then you can consider again that reculturing at the end, especially if you're doing a guide wire catheter exchange, okay? Now, it would be more reasonable to take the catheter out and then continue antibiotics, document clearance of infection, and then replace the catheter. That would be called delayed replacement. If you have a patient who is not defervescing, right? Of course, if they're septic, you don't want to do this, okay? Also, if they're not defervescing, right? After 2 days, they're still febrile, for instance, when they come back to dialysis clinic those 2 days later, or if they still have positive cultures, if you've checked another set of cultures. If you're dealing with Staph aureus, given the rates of metastatic complications, most people would say respect Staph aureus, do not do a guide wire catheter exchange. However, the studies that support guide wire catheter exchange, which were not randomized controlled trials, those studies were basically prospective studies of outcome with guide wire catheter exchange. Those studies included patients who even had Staph aureus collapses. So there was not in those protocols a decision that if you had Staph aureus, you cannot do a guide wire catheter exchange. That being said, I would say that most practicing nephrologists would respect Staph aureus and say, don't do a guide wire catheter exchange. Do delayed replacement for Staph aureus. Enterococcus might be another. Certainly, fungal infections, we would not want to do a guide wire catheter exchange. And then some would say also delayed replacement is appropriate for pseudomonal infections or if I have a polymicrobial infection. I would say there's fairly uniformity of practice, a fair amount of uniformity of practice for Staph aureus and candidal infections, saying guide wire catheter exchange shouldn't be done, especially for Staph aureus and candidal infections. The Enterococcus, the Pseudomonas, and certainly I would say polymicrobial infections. Most people would also have agreement around that. Don't do a guide wire catheter exchange. Okay. Now, other reasons I might want delayed replacement is when I have obvious exit site infection with the CLABSI, because of course, you want to try and make that exit site in a different spot. Or if I have a tunnel infection, right? We'll talk about what a tunnel infection is shortly. It's basically where I have erythema along that tunnel, that subcutaneous tunnel, or I can milk pus out of that tunnel. Okay, you should be trying to squeeze around that tunnel and seeing if you can milk pus. Certainly, if I have metastatic infections, I would also be reluctant to do a guide wire catheter exchange. Okay. Moving on, exit site infections. This would be an individual who has erythema or a little bit of pus at the exit site, but has no systemic symptoms. It's not febrile. That would be considered an exit site infection. Okay. You can see a cuff under the skin. Hopefully you've examined plenty of catheters. If you haven't, please start doing that. You need to be able to manage these, have confidence with making the diagnosis of exit site versus tunnel infections. So these catheters, obviously these tunneled catheters, hang out of the neck. Typically they're pointing downward. You have that exit site, right, where the catheter dives under. And then you can see this tunnel under the skin, and you typically have two cuffs that you can feel. You can rub your finger along the catheter and feel a ridge near the exit site, and you typically have another cuff further proximally before it dives over the clavicle and into the IJ. So I have my IJ where it's diving in, right? I go over the clavicle and then I'm diving into the IJ. So you can feel this cuff, all right, and this cuff as you palpate along the catheter. There's also an internal and external cuff in PD catheters. So you can examine PD catheters. I encourage you to palpate along the track, try to feel that ridge that shows the external and internal cuffs. And occasionally you have a patient with the external cuff showing, both in hemodialysis catheters and PD catheters. That itself is not a strong indication that that catheter needs to be removed. I would say we're probably less accepting of an externally exposed cuff for hemodialysis catheters. PD catheters were fairly accepting of that. But again, HD catheters, there may be a little bit more enthusiasm for changing out those hemodialysis catheters. The cuffs are these attachments that the skin and connective tissue is holding to keep that catheter secure. When you have infection, often there's breakdown of the skin and connective tissue that's holding on to these cuffs, and the catheter is more easily removed. Sometimes they even fall out when they're overtly infected with a tunnel infection. Okay. Again, an exit site infection would be an infection that is limited to this part of the catheter, right? Exit site and the distal catheter, distal to that cuff. Okay, once you start having evidence of infection beyond that cuff, we are calling that a tunnel infection. Erythema and pus might be evident in those tunnel infections. Now, with exit site infections, you can treat those with oral antibiotics or IV antibiotics. You might obtain a wound swab. Granted, these are often, not so helpful in determining the organism because you have all kinds of things on your skin. So those are less reliable, but we would typically treat those at least for 7 days. And once I'm seeing that catheter exit site looking normal again, okay? So it could be more than 7 days. Tunnel infections, again, inflammation, purulence, that's deep to the cuff. These must be managed as catheter-associated bacteremias. You have to remove these catheters and place the catheter after clearance of infection in a different site, or at least a different track. Okay, if you don't go to the other side, you at least need to go to a different track on the same side. AV grafts and AV fistula infections, essentially you treat these like endocarditis. They're endovascular infections. And so you're treating these for a minimum of 6 weeks. If you have grafts, most of those require debridement, okay, or removal, all right? So AV fistulas, not necessarily. You can, treat heavy fistulas like an endocarditis essentially, right? We don't change a native vessel. We don't change, native valve endocarditis unless you start having, severe valvular dysfunction or septic emboli. That would be similar consideration if I have fistula infection where I'm having embolic phenomenon. You need to get that nidus of infection out. You can't wait for weeks of ongoing emboli to just ride that wave and continue antibiotics. You need to get that out. Grafts often require at least debridement, if not removal, because that's a foreign body there. It's really hard to eradicate that biofilm when you have that fomite in place. Okay, so that's all I'm going to talk about when I'm describing some of the infectious complications of hemodialysis. Let's move on to other complications of hemodialysis. One you might say is I have a low dose and I'm not achieving my desired KT over V. So certainly the most common cause of insufficient dose is my time is not long enough. Either the patient is signing off early or I just am not prescribing sufficient time. And the patient may be signing off because of clinical events. Frequently our patients have diarrhea as well, and sometimes that's requiring them to come off the dialysis machine early. Cramping would be another, late arrivals, that would be yet another. Okay, if you excluded time as a explanation for low KT over V, now I'm looking for problems with K. Remember the determinants of K, the most potent of which is blood flow. Dialysate flow is another. We talked about dialyzer being the least impactful effector of K changes in K, right? So blood flow is the one that you need to certainly think about as well. First, again, we don't typically have problems with dialysate flow rates or dialyzers. Blood flow rate can certainly go down because I'm having catheter problems or access problems or my needles are in against the wall. So remember, blood flow rates, look to that. What is your bedside assessment that the access is working well? Remember, you want an access pressure that's less than half of your blood flow rate. So if I'm running 400 blood flow rate, I'm looking for access pressures either on my return side or my pull side. You want them less than 200, right? If I'm running 400 blood flow. Remember, again, that's with normal size needles. Don't get fooled if you're using 17 gauge needles. Everyone's going to have high access pressures. Okay. So access dysfunction, needle placement, those would be another problem, another cause of low blood flows. Now, I might have a higher than expected V. Remember, when a patient is volume overloaded, you can't just say your V is 60% of total body weight, right? So if I have a volume overloaded patient, that may also result in a lower than expected KT over V. All right, so keep that in mind. Dialyzer problems, the dialyzer is clotting. Usually that's impacting not so much the K, but usually the dialyzer is impacting T. That's the main way that your KT over V's drop, because as I mentioned, the surface area of the dialyzer is typically more than enough that you need in order to achieve the urea clearances that you demand. What is the typical urea clearance? Remember, a typical urea clearance for dialysis would be somewhere around 300, okay, mils per minute. What do these dialyzers give you? Well, they can have an effective urea clearance that's much more than 300. Typical dialyzer, high efficiency dialyzers have this mass transfer area coefficient. That's the maximal urea clearance that they can achieve. That's well above 300. So when you're clotting some of those capillaries, you're typically not meaningfully dropping K through loss of surface area, but you may have problems with time or lower blood flows as that dialyzer is clotting and pressures are rising. Okay? Access recirculation. We talked about how you can measure access recirculation. There's a formula that I provided you up here. Remember, you can do an indirect test looking for access recirculation through those transonic machines. Transonic machines are those often used machines for access surveillance. You typically get flow rates, and then they reverse the needles in order to measure a recirculation. And you can then do a formal recirculation study through this methodology that I described, transiently turning down the blood flow rate, measuring the so-called systemic, arterial, and venous concentrations of urea. Okay, so access recirculation will decrease KT over V. Sometimes you can, I'm throwing a lot of terms at you, hopefully you're digesting this. Sometimes you can get a quick look at what's happening to your K by measuring the sodium conductance, right? The KECN. Remember, we talked about KECN as being a surrogate of small molecule clearance, right? Up here somewhere, right? You can do those online clearance measurements, okay? Where I put it, just in the interest of time, take my word for it or page through your field guide. You can do a quick measurement of KECN. KECN is simply your K term in the KT over V, right? And if I have a low K on my KECN, I would first look at what's my blood flow rate. If my blood flow rate's running at only 250, well, why is it running at 250? My access pressures are high. Okay, so now you've sort of troubleshot that at the bedside. K is low. K is low because blood flow is low. Blood flow is low because access pressures are high. So that would be a typical way you would parse at the bedside. What's going on with my patient? If my K is low, but my blood flow is fine, right? I'm running 400 blood flow. Obviously, you want to make sure for some reason the nurse is not doing something weird with dialysate flow rates. That would be weird if they're running low dialysate flow rates. That's typically not happening. You then should be jumping to the conclusion, maybe I have access recirculation, explaining my low K. Okay, so you can see how this can be done at the bedside as well. Not every machine is capable of measuring these sodium conductance or online clearance measurements, but you can get this. We do this fairly frequently in our CUH unit. So I encourage you to do that. You can push the buttons, ask nursing to show you how to push the button to look at Ks, your online clearance. You should be able to do that. And I encourage you to do that in your VA dialysis rotation as well. I'm told those machines do it as well. Okay, cardiopulmonary recirculation. All right, that could be, I think I alluded to this. This is unavoidable, okay? Access recirculation is typically avoidable unless you have a poorly functioning catheter or an access that is poorly functioning, or don't forget, inadvertently, sometimes nursing can place needles in the wrong direction. They can place needles on the wrong side of the fistula, right? And so that can create recirculation. So before you jump to the conclusion that access recirculation is high, we need to send this patient to an angioplasty, you should just make sure, especially if it's an abrupt change. Do we have the needles on the right side? Which side is the pull side? Which side is the return side? You can do that at bedside. How do you know which side is the pull side or the pull side? Sorry, I said pull side or push side, right? Let's suppose you have some arbitrary loop that describes your access. You occlude the access with your thumb or finger, okay? And the side that is pulsatile, right, is obviously your inflow. Okay, the side that's collapsed is going to be your outflow. So that's how you determine what side should be my pull side for my needles, right? My arterial needles should obviously go on my pull side. My venous return would go on the return side. If you've inadvertently flipped these, you would obviously have recirculation that's happening. Okay, so make sure that that's not happening as a first step before you jump to the conclusion that I have access recirculation because I have a stenosis that's happening, where again, I'm pulling blood on my arterial side, turning on my venous side. Instead of that going back out to the patient because of a stenosis, I'm actually pulling that already cleaned blood through my arterial needle again. Okay. So these venous outflows are the most common place for stenosis to occur. Okay, so this access recirculation is one example of where access complications can manifest. Okay, so cardiopulmonary recirculation, again, is a different form of recirculation that happens simply because when I have a graft and fistula in place, when I'm returning blood to this, fistula, okay? When I'm returning blood to this fistula, it has a shorter path to get to my heart than the systemic blood, right? I have my heart, right? I'm pulling from my arterial side, okay? I'm returning to my venous side. That blood, because it's in this fistula, goes back to the heart. I'll do that color. Goes to the heart, goes out the arterial side, and goes back to my access faster than the blood that is going from the heart out to my tissues and then returning back to my venous side. So there is always unavoidably some what we call cardiopulmonary recirculation when you have a fistula or a graft in place. When I have a high output fistula, a very large fistula, okay, or if I have a cardiomyopathy, so I'm going to make that a small heart, those would predispose to greater amounts of cardiopulmonary recirculation because the flow through the fistula assumes a greater proportion of the total cardiac output.
But they're not.
Okay, so again, large fistulas or weak hearts predisposed to greater amounts of cardiopulmonary recirculation. Okay, and sometimes both are at play. Weak heart plus big fistula. Okay. And the usual cardiopulmonary recirculation for a typical fistula in a normal heart is around 5 to 10%. And again, high access flows and low cardiac output would predict greater amounts of cardiopulmonary recirculation. Okay. Intradialytic hypotension, another side effect that you may deal with in a dialysis patient. The predisposing factors would be cardiomyopathies and autonomic insufficiency. The classic diabetic patient cannot defend their circulation as well with vasoconstriction when you're acutely dropping the blood volume, and you are. And if you do, or people have done echocardiograms on patients doing hemodialysis, most of those patients are having wall motion abnormalities that are happening during the course of dialysis. And they're actually having myocardial stunning throughout that treatment. Okay, so that's a fact. That is the direct result of the burden of cardiovascular disease in these patients, as well as the very non-physiologic stress of dialysis, where you're emptying the intravascular compartment faster than they can refill it. It's extravascular volume excess. Okay. The way we manage this might be using high calcium dialysate. You don't want to do that chronically, right? Our patients are predisposed to vascular calcification. So putting them in positive calcium balance with high calcium dialysate would be a bad idea in the long-term management. However, if you want to get a patient through an intermittent run in the acute setting, either because of acute kidney injury or an ESRD patient who's not doing well, it makes sense you might try higher calcium dialysate for a couple of treatments. Lower dialysate temperature is also a way that you can cause them or enhance their vasoconstrictive response. But some of these patients are frankly chilling on dialysis, and it can be uncomfortable for the patient. But lowering the dialysate temperature is another strategy, especially if the patient is, intubated or can't tell you that this is uncomfortable. Sodium profiling is another one to potentially utilize in the patient who cannot respond to the thirst that would occur by sodium loading your patient. What is sodium profiling? Sodium profiling refers to the fact of dialyzing the patient. Here's my blood. Okay, blood side. My blood is running with a dialysate concentration of, a sodium concentration of 140. I'm running dialysate in a way that I start out with a dialysate concentration of 145. And then during the course of the dialysis treatment, near the end, I then dial it down to 140. This would be sodium profiling. What are you trying to do? Well, as I am dialyzing a patient, what's happening is their intracellular urea concentration may be 100. I am dropping the extracellular urea concentration rather quickly, and there's a disequilibrium between the ICF and ECF. And so water tends to move from the ECF into cells. This is one of the causes of cerebral edema and dialysis disequilibrium that we sometimes see. But it also theoretically lowers the intravascular volume and predisposes to hypotension. And so if I raise the sodium concentration to 145 instead of that resting 140, then that would mitigate some of this transcellular water removal or movement, and therefore maintain blood pressures a little bit better. There may also be a direct effect of raising the sodium concentration on vascular tone. People have described that sodium loading is not simply all volume. It also may enhance vasoconstriction in patients or increase vascular tone. So even in hypertension, people have used that as an alternate mechanism whereby salt loading or avid salt intake causes hypertension, not just from chronic volume overload, but actually increasing vascular tone. Okay, so sodium profiling is one other mechanism or one other intervention to mitigate for drops in blood pressure. Ultrafiltration profiling is changing the rate of ultrafiltration throughout the course of the treatment. You can do it in a variety of different ways. None of them are proven to be superior. Ultrafiltration profiling might start out with ultrafiltration rates instead of it being a steady, let's say 500 mils per hour, right? What are typical ultrafiltration rates that we're prescribing? Anywhere from 500 to no more than 2 liters. Occasionally, I will go to 2 liters in somebody who's on BiPAP with a blood pressure of 230. You don't want to do that commonly though. But remember, your blood volume is only 5 liters, right? So you're removing 2 liters an hour. That's a lot of hemodynamic challenge for your patient, right? So a typical walk in the park might be 500 mils per hour of ultrafiltration. So that would be one. If I wanted to do ultrafiltration profiling, I might start off with, let's say, 700 mils per hour at the start of treatment, and then gradually it decreases to 300 near the end, taking off the same total ultrafiltration as opposed to, again, this slow and steady. There are linear ultrafiltration profiles. They're so-called step profiles. You know, nursing sometimes will ask, you want to try a profile? Sure. What profile? Stepped, linear, I don't know, whatever you want. Okay, so, those would be reasonable responses to the nurse. Okay. Albumin bolusing, you've tried, of course. Mitodrin, you try. And then rarely you might even try UF alone, followed by hemodialysis. So ultrafiltration alone is typically hemodynamically more tolerated than the clearance plus ultrafiltration. Again, the mechanism of that enhanced tolerance, we talked about that transcellular water shift that happens as you're reducing the tonicity of the ECF with dialysis. So sometimes you might just want to ultrafilter first for the first, let's say, 2 hours, 3 hours, and then obviously this will be a longer treatment, and then you do dialysis for the next half of the treatment. Okay, that can be considered. All right, cardiac tamponade is another potential explanation for hypotension. Our patients are predisposed to pericardial effusions, arrhythmias, and then anaphylaxis or anaphylactoid reactions, the so-called dialyzer reactions. You have to think about these, know these as well. Okay, so the anaphylaxis or anaphylactoid reactions will typically happen early during dialysis. They have a variety of symptoms. Hypotension is one of those symptoms. You might have the sense of burning. You might actually start to have frank angioedema. Cramping is a nonspecific symptom as well. What are the etiologies? Well, some of these are the sterilants, the ethylene oxide sterilant. There's a variety of ways that you can sterilize dialyzers. And, you can use radiation, they can use various chemicals, including ethylene oxide. That would be one example or one causal factor in some patients who have an adverse effect from ethylene oxide. Other sterilants can do it. The combined use of ACE inhibitors with AN69 membranes is an instance in which bradykinin levels can be quite high. AN69 membranes can activate bradykinin. The use of ACE inhibitors impairs the clearance of bradykinin. So the combination of the two can predispose to this form of hypotension. Our typical dialyzers that we're using in maintenance dialysis patients are not these AN69 membranes, but your dialyzers in CRT machines are AN69 membranes. So the M150s and these ST100s, those are AN69 membranes. You don't typically have this effect because obviously on CRT, you're typically not using ACE inhibitors in patients who are in shock. But every year we do see some instances of these dialyzer reactions. You don't need an ACE inhibitor to manifest this AN69 reaction that is caused by bradykinin activation, okay? And then rarely you might have a heparin allergy that's also causing this hypotension. Management involves stopping the treatment, don't return the blood because of these, the returned blood could have, could further worsen the reaction. Now, occasionally you may have these so-called type B dialyzer reactions. That can happen as a result of complement activation for these membranes that the individual may have biocompatibility with. These can be pushed through. Okay, so if you have frank hypotension, angioedema, you're not going to want to try and push through those. Okay, you stop the treatment, don't return the blood, and the patient typically recovers. Now, if you have someone who's just having sort of mild itching, a subtle drop in blood pressure without overt symptoms, you might consider again just sort of riding through that. And typically the treatment gets smoother as you continue to go along. Now, the clinical clue would be, a drop in neutrophil count early in the treatment with these milder reactions. And then you actually see a bandemia later on. Okay, and some of these are just simply related to the complement, C5, these anaphylatoxins that are affecting neutrophil margination and activation. Okay, air embolism. Signs of air embolism would include chest pain, dyspnea, hypotension, or neurologic symptoms. We would typically put the patient in Trendelenburg with the left side down. You're trying to sort of keep that bubble from essentially in the right atrium from going into the left side of the heart. Okay, so you're trying to keep that air bubble on the right side of the heart by putting the left side down. Okay, and then you would gradually resorb, or those would gradually be removed by using high oxygen ventilation. Okay, hemolysis can occur with certain water contaminants. That shouldn't happen these days with all of the water treatment and monitoring that is standard practice in dialysis units. Sometimes there can be problems with heating or dialysate mixing, but that shouldn't be something that you see very often. Dialysis disequilibrium. We talked about one of the mechanisms, the flow of water into cells as the ECF tonicity drops. Risk factors for dialysis disequilibrium include very high BUNs at the start of dialysis, a K/V that is above this rate. K/V is essentially a rate of dialysis, right? The time term is removed from KT/V. So this refers to a relatively high clearance or a high clearance for a small volume of distribution. That would make a higher K/V. So smaller patients with high BUNs are especially high risk for dialysis disequilibrium. A small patient with high urea would be more at risk for dialysis disequilibrium through V being in the denominator of the K/V term. Okay. First dialysis treatments, organic diseases of the CNS, hyponatremia, pediatric patients and older age. Maybe that has once again to do with that smaller volume of distribution. And again, the change in BUN is not so relevant. It's really how fast the change has occurred. And so running CRT essentially has no risk of dialysis disequilibrium, even though urea concentrations may change dramatically from time 0 to time 24 hours, because K/V is quite low in CRT, even though, again, the size, the BUN may change over 24 hours a great deal. Okay, headaches, nausea, and then seizures are the most overt manifestation of dialysis disequilibrium. If you happen to do a CT scan on these individuals, you will see cerebral edema as a imaging correlate of that phenomenon. Okay. Occasionally, you can see increases in blood pressure during the course of dialysis. Why does that occur? It's probably related to that intravascular volume depletion that is happening. And then as a result of that, you get a spike in angiotensin 2 and catecholamines. And then you have this vasoconstriction resulting in an increase in blood pressure. And so the individual that is young is more apt to have that robust sympathetic and angiotensin 2 response to that abrupt lowering of intravascular volume. And then others, investigators, including Peter Van Buren, when he was a fellow, published on clinical volume overload as being a risk factor for this intradialytic hypertension, right? That's blood pressures that are rising during dialysis as you're removing fluid. So he and his mentor at the time would suggest, challenging someone's dry weight when you have this phenomenon of intradialytic hypertension. You certainly want to reduce the amount of ultrafiltration that you demand by telling them to drink less, but you also may want to incrementally challenge the dry weight. Some, again, investigators have, again, shown chronic volume overload as being a risk factor for this intradialytic hypertension. Okay, so gradually reducing dry weight, reducing the gains between treatments. Also consider changing blood pressure meds to those that don't have much dialytic clearance. For instance, carvedilol is a good one. It doesn't have much clearance. Your ARBs are generally not cleared by dialysis. Not all ACE inhibitors well, there's differences across the ACE inhibitors of which are cleared by dialysis and which are not. Metoprolol is generally cleared by dialysis. So carvedilol has some advantages over some of the other beta blockers. Okay. And then one can also try to reduce dialysate sodium concentrations in order to reduce positive sodium balance that may happen, right? A patient who's drinking a lot may come to dialysis with a sodium concentration that's significantly less than 140. And so if you're dialyzing a patient with a dialysate sodium concentration of even 138, right? If a patient is drinking a lot, they may have a pre-dialysis sodium concentration of only 130. And when you're dialyzing someone against a dialysate sodium concentration of 138, even though that's less than 140, you may actually be sodium loading the patient during the course of dialysis. So lowering dialysate sodium concentration below the serum sodium concentration might also be a strategy to reduce this phenomenon of intradialytic hypertension. Let's round this out, then we'll finish. Cramps might include this abrupt drop in intravascular volume. It may also be due to the drop in tonicity that's happening abruptly during the course of the dialysis treatment. There may be some, let's call it epiphenomenon, low magnesium or low carnitine that may predispose to cramps. Lowering ultrafiltration rates, either by increasing time. Well, we typically have to stop the ultrafiltration rate if the cramping is really severe, and then resuming at a lower rate by increasing time or reducing the ultrafiltration goal. Those would be considered. You can give hypertonic fluids, such as D50 or even 23% saline would be a consideration. Most of the time, we're just stopping ultrafiltration and giving back normal saline. That's the typical intervention that is done most commonly. Okay, again, prevention, try to reduce the ultrafiltration rates. If the dry weight is too low, you obviously want to increase the dry weight. And then sodium profiling and carnitine supplementation may also be interventions that you may consider. Finally, intradialytic hypoxemia is a phenomenon that happens when you have low reserve. If you have a sensitive enough test, every individual will have a slight drop in their arterial PaO2 during the course of dialysis, okay? But typically it's subtle, and because you have more than enough oxygen carrying capacity in your blood, it's of little relevance. If you have a patient with PH or severe COPD, it can become clinically significant, okay? Why does this happen? Well, it's happening because you're giving them a bunch of bicarb. And so if your serum bicarb goes up, your pH becomes alkaline, your response is to hypoventilate, right? So you're often dialyzing patients with a bicarb of 35, 38, or even 40 in some instances. So that bicarb's rapidly rising. A normal respiratory response to that is decreased minute ventilation. If you decrease minute ventilation, PCO2 goes up and PaO2 goes down, okay, through the relationship between O2 and PCO2 through the alveolar gas equation, okay? You might actually be removing some modest amount of CO2 in the dialysate. Another factor is, remember we said that there's this activation of neutrophils that are happening in some in these type B dialyzer reactions, okay? Everyone has a little bit of leukocyte activation and margination in the pulmonary vascular or the pulmonary arterial bed. And so that can also reduce the efficiency of gas exchange a modest amount, okay? The prevention might be using more biocompatible membranes, and then using sequential ultrafiltration to remove any of that pulmonary edema first, and then the dialysis kicks in later. Those would be considerations for individuals. Okay. All right. You should remove this bicarbonate-based dialysate because we don't use acetate dialysate anymore. So everyone is essentially getting bicarbonate-based dialysate. So I should remove that. Okay. Questions?